Good evening, everybody. Welcome to this meeting of the Health and Adult Social Care Committee. Welcome to officers and also to members of the public. Before we proceed to the main items on tonight's agenda, I'll hand over to the Democratic Services Officer, Karen Tompkins, to go through items 1 to 5 of tonight's agenda.
Many thanks, Chairman. Before we get into the agenda, if I can just do the housekeeping notice, and just to confirm that this meeting is being audio recorded by the Council for subsequent public broadcast. The meeting may also be audio recorded and all filmed for live or subsequent broadcast by members of the public. Please could I remind members and officers that when they wish to speak during the meeting this evening, that please use your microphone so that we can pick up your comments. There are obviously no scheduled fire alarm tests. If the alarm does go off during our meeting, please leave through the emergency exit at the back of the room, obviously the door that you came in through, and assemble at the front of the town hall. Finally, before we actually start the main business of the meeting, could I ask that you switch off mobile phones for the duration of the meeting, please? So if we can move to the agenda and deal with item 1. I've not been notified of any apologies for this meeting, unless anybody is aware of any. Nope. Okay, so consequently, item 2, substitute members. There are no substitute members that have been notified for this meeting. In relation to item 3, can I ask members to make any declarations of interest in respect of the issues that you have set out on the agenda? And can I also include the items of AOB that have previously been circulated to members at the end of last week? Councillor Allen?
I'd like to make a declaration of interest that I work for NHS in the area. Thank you.
Can I ask if there are any others?
Thank you, I do too, thank you.
For transparency, I'm also an NHS bank employee.
Thank you again for transparency. I'm a governor of the NHS, Dorset NHS governing body.
So I think if I refer to the second page of the action sheet, minute number 38, forward plan, asks us to make contact with Dorset Council on the joint scrutiny protocol. And I think there are 2 issues that have been identified by this committee for joint scrutiny. One relates to the ambulance service, and I think the other is the urgent integrated care service, if I've got that terminology correct.
Urgent integrated care service.
The Dorset Council Health ONS Committee actually met last week, and the feedback that we've had from the chairman of that committee, and I know Councillor Northover is in contact with her, is a suggested possible timescale for those 2 issues of probably June/July of this year. In addition to that, we are looking to review the joint protocol because it does need to be updated. We're a new authority and therefore it does refer to preceding authorities. And again, as officers working with Dorset Council, we will be undertaking that piece of work. So it was just to provide that update, Chairman. And then if I can move to item 5 on the agenda, and then I'll hand back to you, which is public issues. I can report for this meeting we have no public questions, no request to make statements, and no submission of petitions. So that deals with items 1 to 5. I'll hand back to the Chairman.
Thank you. I just want to remind everybody that there is 2 extra urgent pieces of business that we're looking at today. One is the clinical services review, and the other one is the budget items. So this has changed our running order to item 6 now is the clinical services review, 7 is the adult social care point of first contact, item 8 is the budget, item 9 is the review of local safeguarding adults boards, 10 is the emergency duty services, 11 is the forward plan, and then 12 is the future meeting dates. And so now on to item 6, we're going to look at the clinical services review. This item concerns the outcome of the independent reconfiguration panel and the Secretary of State's response to that. And I'm going to ask Jan Thurgood to update us all as appropriate. And this is with reference to the 2 documents that have been already circulated via email before the meeting.
Thank you. I was to just ask, as this is a very important topic for our town, if it was not worth to have a separate meeting talking about this point. I mean, the clinical service review, even the budget, because I can see that the agenda for tonight is very busy. And so when I received the email, I didn't understand why we are putting all together, and then maybe we had to stay here long time talking about or just listening what's happened so far. So that is. Thank you.
Yeah.
With the Chairman's permission, I'll just do an introduction on what we were intending for tonight. So, in terms of tonight, the purpose of bringing it today was to note that the Secretary of State has made a decision in the light of the advice of the Independent Reconfiguration Panel. It wasn't intended that this would be a process of full scrutiny. So if I just do an introduction, and then there is a proposal about how the committee might look at this over some time, because what we have to remember is these changes are so significant that they will take 5 to 6 years at least to deliver. So I'll just come back to what the committee might want to consider that it does in relation to the outcome. So just to note that the papers that were circulated was a letter from the Secretary of State to Councillor Pipe, who was the chairman of the Dorset County Council Health Scrutiny Committee when the referral was made. So that was made by Dorset County Council prior to local government reorganisation. And basically what the Secretary of State says, he has received the advice of the Independent Reconfiguration Panel and has been minded to accept the proposals, which are that the proposals of the Clinical Services Review by the Dorset Clinical Commission Group should now proceed. I think what's particularly important is to maybe just focus on page 9 of the Independent Reconfiguration Panel's advice, in which in which is the conclusion. And I suppose if we just summarise the conclusion, which is that the proposals were developed over a long period of time and they commanded the confidence of local clinicians who led their development, that the conclusion of the independent reconfiguration panel was that the approach is comprehensive and that changes to services will be incremental and considered carefully at all stages. And the panel considers the proposals are in the interest of local health services, will improve outcomes, and that the 5 tests that they use have been met. It encourages people to work constructively going forward, and particularly notes that it would be really important that all parties, the NHS, local government, Health Watch and public and patient groups really work together in terms of moving things forward in a constructive relationship. The panel also noted, because the Secretary of State, when he wrote to the panel, did raise this issue of whether there was an applicability of an emerging model in the NHS of something called A&E local. Now, what is important to note is that the A&E local model is not yet fully developed at national level, and the guidance about it has not yet been published. So what is proposed in the letter is that the Dorset CCC and the local NHS would really keep abreast of the developments, and at the appropriate time would be looking at the local, the national model, and thinking about local services in the context of what is an emerging national model. So those are the conclusions, and in terms of therefore taking forward and the responsibilities of this committee, having talked to the chairman, one of the things that the committee may well want to do is the committee spent quite a lot of time developing its programme for this year, and it may well want to spend some time in development sessions looking at its programme for next year and the future years. And the suggestion is that the committee would want to look at how best to deliver its functions in relation to the major changes in health, and develop for next year its programme of detailed work and scrutiny of local health services and the implementation of these changes. So the proposal, it is absolutely a very, very significant change in local health services. This committee will no doubt want to be understanding the plans for implementation, and also really looking at the benefits for local people and how those are going to be delivered. We have to remember that is over a long period of time, so the committee may well want to be saying how is it going to do that work over a considerable period of time. But the purpose today was to say these have been received, and to really propose to the committee that now the Secretary of State has agreed with the IRP that the proposal should proceed. It would be then for the committee to determine how it wanted to engage in that process and scrutinise impact over time.
Thank you. So as a committee, thinking about how we are going to deal with this and think about scrutiny in the future, are we happy to take this to our next development day or workshop and consider at that point how we're going to be scrutinising how this is rolled out over the next few years? Yes?
Yes, Chair. I have to say that I'm bitterly disappointed but not surprised at the recommendation, and I'm sure it'll be presented as upgrade of 2 hospitals and a new A&E thing by the powers that be above. But you know, I think in the light of our desire to be greener and reduce travel times, I just think this goes completely against the grain. And the other thing I really wanted to say is, tucked underneath this but not being publicised in the same way, are the differences in the changes in maternity. And I know that when I had my 2 children. I didn't have transport at the time, and actually having children in Poole was very useful. I was born in Poole. My parents were born in Poole. They both passed away in Poole, and I just think this is actually quite sad, and I regret it, but there's not much we can do about it because the decision's been made elsewhere, and we've just got to make sure it works as well as possible, and there may be 1 or 2 things up for discussion in the future, as the ability to reopen on an emergency basis and A&E if there was a major need for extra capacity proven in the future. I really hope they don't throw the baby away with the bathwater. But as I say, I'm disappointed with this, and I just think it's a sad day. But still.
Thank you. Oh, Lisa.
Well, I just want it to be on record that I echo Tony Trent's comments. I'm very disappointed as well.
Okay, thanks for your comments. Those comments aside, though, and looking forward, are we happy with the proposal that we would look at this when we're thinking about our forward plan and how we're going to scrutinise over the next months and years? Yes. Yeah, thank you. Okay, so on to item number 7. This is the Adult Social Care Point of First Contact Service Design, and our lead officer, David Vitti, is going to present and speak to this report.
Can I start, Chair, by apologising? We seem to have a connector problem, which has turned the presentation into a somewhat fluorescent shade of yellow. I'll press on, but apologies for that. I hope the report and the KPMG appendix have been helpful for this committee. So I won't repeat those in a great deal of detail. But I would perhaps like to pick out 1 or 2 items which relate to our point of first contact, or our front door. So, one back, Joe, please. Thank you. So I think the first question is, why are we doing it? And in answer to that, you can see from this slide that by 2024 we'll have a population in BCP of well over 400,000 people, and alongside that, we know that the demand for adult social care is rising very rapidly, and in fact, it's risen in Poole by 22% in the last 3 or 4 years. It's actually quite stable in Bournemouth, and that reflects our demography. There's fewer older people in Bournemouth as we track the years forward, but we know that the population in Poole is ageing. We don't have the numbers for Christchurch because it was hard for Dorset Council to disaggregate those and compare them accurately with Bournemouth and Poole, but we know the population is rising there too. We also know that 50% of people aged 65 and over have a long-term limiting illness. And we think that 23% of the population will be over 65 by 2024. So there's a clear demographic set of demands on us as a council, and particularly on adult social care. We're not going to be able to respond to those by simply growing our services and putting more money in. We're going to need to find different ways of responding to that demand. And the other reason we need to act is because we currently have front door systems that are inherited from the preceding local authorities in Bournemouth, Christchurch and Poole. Collectively, they deliver about 34,000 perhaps nearly 35,000 individual contacts into adult social care every year. So there's an enormous number of demand or of contacts rolling in. But at the moment, they either go to the Care Direct service in Bournemouth or the Help Desk service in Poole. Christchurch demand goes to the Bournemouth Care Direct service. And actually, there is a next slide, which I'm not going to show you, but I'll whiz by it, because what it did, that was pretty quick. What it would have done was show you what a complex wiring diagram we have at the moment, and how that demand rolls on into 2 different front doors that operate in 2 different ways, and they do different things with the demand. They very often take referrals quite quickly and pass those referrals through to our long-term fieldwork teams. And actually, that's where demand gets quite expensive for us. So we need to simplify that wiring diagram. And this slide you can see here is more like a funnel. And it's actually quite hard to read, but you should have it in the appendix to your report. And if we follow it from the left-hand side, our proposal is actually to make sure that our communities are able to help people resolve problems before they would even come to us as a council for assistance. So we need to look at what information people can reach for themselves, what information they can find online, and we need to look to partners in, say, primary care to understand how people can be supported in their communities. As we move along the funnel, we then need to look at engaging early with people when they do come to us for support. And sometimes, actually, that's going to be reaching out to people who are very likely to need our support, but reaching people early. We know, for example, that a lot of people fall locally, and that leads to fractured hips. People who go into hospital with a fractured hip very often need a care package when they come home. So it makes a great deal of sense to try and help prevent people falling. There are already fall services across BCP, but we think we can do a lot more at the front door by reaching out to those people we think are vulnerable and perhaps likely to fall. And with a bit of occupational therapy advice and support, we might prevent that fall and reduce the demand. So early intervention, but then when people do reach our front door, we want to make sure that front door is staffed up in such a way that we can provide really quite detailed help for people at the point they contact us. At the moment, we provide advice and information. In Poole, we might even visit people from the front door, but it's a relatively shallow service. And this model is all about having occupational therapy, social work, safeguarding experts, and then perhaps the voluntary sector as well, right there in the front door, so that at that point of first contact, we can do an awful lot more to support people. We can provide equipment, we can perhaps provide simple care packages, we can adjust care packages, we can visit people much more often. And actually also maybe what we can do is have community-based points of contact. Already we run bathing clinics, so we have 3 locations across BCP, and we invite people to come to these clinics, and we'll give them a bathing assessment, provide advice, support and information. So part of this is about saying, how can we see our local residents at the point of first contact that maybe isn't in their own home, but in some form of assessment clinic. And only then will we pass referrals through to our long-term teams for long-term care packages. So the overall outcome of this is we'll provide a much better quality of customer service, much more of people's problems will be resolved at that point of first contact, much more personal contact when people need it, and we'll try and prevent people deteriorating or even needing services at all. So perhaps if we could move on to the next slide. Again, I'm afraid a little difficult to read on the screen, but again, this is with your papers. And this is a wheel that breaks down our services, or our proposed services, into 4 different themes. Engaging early, really good customer contact, assessing people's need at the front door, but then also community empowerment and resilience. And I won't go through all of these, but I'll pick out a couple. Under engaging early, we want to reach out to people. KPMG have called them community navigators. I'm not sure we'll use that term. We already have an emerging system of social prescribers in primary care. But the question is, how can we use people who work for the local authority or for primary care or Dorset Healthcare to support people in their own communities. If we go back around the circle anti-clockwise under community empowerment and resilience, we're also looking, as I've said earlier, about information hubs. So could, for example, libraries or other community services be places where we can invite people to come meet with a social worker or an occupational therapist and receive some advice and support? Under assessment, you'll notice there's a box that talks about access to assistive technologies. We might talk about assistive technology later in the evening when we look at the medium-term financial plan, but we recognise that there's all sorts of technology available now which supports people to be safe and independent at home. There are GPS trackers which allow people with learning disability to access their communities very safely, while others, if necessary, are able to monitor their location. And we have devices which people can use in the home, which monitor their movement from room to room and, in fact, whether they've left the home. That means people perhaps with dementia or confusion can live independently but allow a family member to just track what they're up to over the course of a day and be satisfied that that person's safe. So we think there's a lot more technology that will emerge over the next 2 or 3 years, perhaps in app form, and we're seeing these digital home assistants, and already there are organisations looking to make those more friendly for older people, frail people, people who are lonely, to support them. So we recognise the front door can be a very useful place for supplying some of this technology to people. And then the last one on this slide, under assessment, you'll also see rapid face-to-face and strengths-based contact. Now, a strengths-based approach is, I suppose, jargon to some extent, but it's something that's becoming prevalent nationally in adult social care. And it really means an entirely different approach that says, rather than understanding somebody's needs, but then very quickly jumping to the services that we as a local authority can provide to them, or the services that the NHS can provide, actually, how can we help that person to support themselves independently? How can we look to that individual's family, their friends, community services to support them, so that we're not immediately jumping to service provision, but rather looking to the range of provision that's naturally around individuals, and then only providing services where actually it's really necessary. It's a whole different way of thinking. Perhaps, Joe, if we can move to the next slide. We actually don't have a structure for our new front door yet. In fact, we don't have a name for it yet. But I've put this together, I guess, as an indicative structure, just to help give some clarity about what this new team might look like. We'll need management, so there's some management at the top. We know we'll need that. We don't know what it looks like yet. And then probably there are 3 distinct parts of the team. Going from the left, you'll see that there's call handling. And we know, however technology develops, people will always want to call us on the telephone and talk to us. So we will need call handlers. They won't necessarily have to be qualified social workers or occupational therapists, but we do want them to be able to visit people. We know that people perhaps with communication difficulties or sensory impairment, people with confusion or memory loss, aren't always able to properly articulate their needs over the telephone. So we like to visit those people at home, and we need to do a lot more of that. And there's also other council services. This team of adult social care experts at the front door will in fact be part of the wider council corporate contact centre. So they'll be working with, for example, housing officers, because people don't always approach the council just with an adult social care need. So really important that those call handlers work across a range of needs that the council can respond to. The middle section then is the professional response, and this is where we're really stepping up from what we have now. We want to do more safeguarding. We've been piloting that in Bournemouth, and we know from early pilots that where we have expert safeguarding triage at the front door, able to understand and respond to safeguarding concerns, we're able to reduce the amount of safeguarding inquiries by about 50% that are then passed on to long-term teams for further investigation. So safeguarding specialist social workers, generic social workers as well, who can carry out straightforward social work assessments and resolve need immediately at the front door, and occupational therapists who can look at adaptations and equipment and help people with different ways of managing their day-to-day activities. And on the right-hand side, it's all about partnership. So we have the developing primary care networks, and there are 9 of those across BCP. We want to work very closely with those to say how can the front door and the primary care networks work together to keep people safe and independent and reduce their need for long-term care. Community healthcare as well, and I think principally I'm talking about Dorset Healthcare, but we want to work in partnership with that organisation. And then the voluntary sector. With our commissioning colleagues, we need to look at how we can build the voluntary sector, how we can embark on a different relationship with the voluntary sector, who, for us, will help to provide an awful lot of the support, advice and information that people will need. Thank you. If we can go on to the next slide. So the question is, where will the savings come from? Because as well, I think, as being a much better approach to customer service, this will also release some savings. And KPMG have indicated for us, as our development partner, that about £1 million can be expected in the first 12 months of operation. We'll go live in April of this year. Well, I've pulled out 3 of the themes for our attention in year 1. The first one is the skill mix I've talked about, having those different professionals at the front door. The second one is the community capacity. So how can we rely much more on community services to support people? And the third one is that strengths-based approach, the thinking that actually it's not just the council providing services in order to help people. There's many other things we can signpost them to. So those are the things we're focusing on in year 1, because I think this will be a 3-year programme. And if you can press the button, Joe, this gives a sense of where the money comes from if we focus on those things. I can't tell you exactly where it'll come from, because we're a demand-led service. There's no absolute precision about the people that will approach us in the next year looking for services and what their needs will be. But I can tell you that the average cost of a placement to BCP Council is £37,000. Now that's net of service user contributions, so that's the actual cost of the council. So that means if we avoided or delayed about 27 placements, so that's perhaps 1 every couple of weeks, that would make £1 million savings on its own. And then looking at domiciliary care packages, they cost us on average about £19,000 a year. So £1 million would be the equivalent of about 53 packages, maybe 1 a week. I can't tell you exactly how that will combine, but you can see actually that out of then at the moment it's about 3,000 people every year are eligible for new services. We're only looking at a comparatively small number of people for whom we can avoid or delay services, and that might be somebody who falls. I mean, it's not out of the question that a fall for someone who's frail and older can actually precipitate admission to a care home. So we're not looking at avoiding enormous amounts of demand in order to make that saving. We just have to save what essentially amounts to a handful of residential placements each year, and perhaps a slightly larger handful of domiciliary care packages, or some combination of the two. And then if we look ahead, because we have also projected savings for between 2021 and 2023, this is where we can bring in some of those other themes. We can look at our digital offer. We won't be able to develop a new website and self-assessment and apps and online information that's really sophisticated in the next 12 months. But I think we can do it over the next 2 or 3 years. And that will undoubtedly allow people to access services independently and online. I think we can also see that the primary care networks will develop and mature, and our relationship with them and the way we work as multidisciplinary teams in the community will develop. And also I think that prevention and early intervention will become more sophisticated over the next 2 or 3 years as we develop new relationships with the voluntary sector. And so, Joe, we think as those additional parts of the front door mature over 2 or 3 years, we think we can find an additional £750,000 in the second year, and then another £750,000 in the third year. So again, I can't tell you with precision exactly where those sums will come from, but I hope giving you a sense of how expensive care packages are, it would seem perfectly reasonable that actually just a modest reduction in that level of demand will release that type of saving. So that's the end of the presentation, but Chair, I'm very happy to take any questions.
Thank you very much. Who was it? Councillor Allen.
Thank you for your presentation. I have a couple of questions. Obviously, prevention is very important. Are you thinking of delivering that as part of your service, or are you hoping that the voluntary sector will be delivering some of that prevention work? Because obviously that's got to be overseen and governance has got to be around that. And just adding to that question, I do agree that there's some amazing voluntary sector provision out there that people could potentially look at before they automatically go through to statutory care. But what is the governance around that? How are you going to ensure that if you are signposting somebody to a voluntary sector, that there's the governance in place to make sure that that provision is good and of good quality? Thank you. Go on, you do it. I can't get this.
Thank you. I think the early intervention prevention is probably a blend, actually. We're looking, for example, at nutrition. So we're developing at the moment some work with our reablement service, but I think it'll spread very quickly to the front door, where as long as somebody gives us consent, of course, we're able to understand their height and their weight, and using a tool make a very quick assessment of whether that person's undernourished. And so, for example, that might just give us the trigger warning that that person's starting to not eat properly at home, might be neglecting themselves, and that would be a trigger for us to go out and visit them at home and perhaps provide some early services to them that we might not otherwise at the moment, because we might not identify that they're neglecting themselves. I've mentioned falls, but also, you know, if somebody who is frail and older calls us, and we have visiting officers and visiting occupational therapists, we can visit people at home now if we have a sense that maybe they're not managing as well as they used to, something we can't do at the moment. That occupational therapist might fit rails or other pieces of equipment at home to prevent people falling, to prevent them losing confidence and needing services. So there is an element of encouraging people to call us where they can't get advice through our digital services, and then us reaching out to see what support we can give them. So that's about us intervening earlier with people. But as you said, I think we can also work with the voluntary sector to do that. We don't monitor and govern every voluntary sector organisation in BCP. What we do have are some long-standing partnerships and relationships with many of those organisations, so we have a degree of confidence that they provide high-quality services and the right advice and information. But as well, I think, you know, working with commissioning colleagues, we might arrange some much more formal partnerships, maybe through contracts or other arrangements, whereby we might provide some monitoring and certainly some expectations of outcomes that voluntary sectors can provide. And we'll be much more confident at directing people at those voluntary sector services because they'll be working in direct partnership with us.
Councillor Edwards.
Thank you, Chair. Actually, I was going to ask something about the voluntary section, but I think that's fine. It was just what it was. Are you talking about the charity sort of area of volunteers, or trying to get the families more involved in it? But I think you sort of answered that really, so that's fine.
I think it's both. I think it's both.
Okay.
Yeah.
On page 27, when you had the case for change. You had requests for adult social care services for people over 65. Do we have any figures for those that need adult social care services under 65? Is that also a rising number as well?
There is an overall rising demographic in the population. So there is a very modest rise in people under 65. However, I don't have those numbers with me this evening. I'm very happy to pass them on to this committee after this evening through the chair.
Councillor Johnson.
Thank you, Chair. Thank you, David. I'm really pleased to see all this prevention work going on. That's great. But what I'd like to know is, how do you identify people at the stage before they need the services so that you can put the prevention in place before they come into hospital?
That's a very good question. We're wondering that ourselves. It's partly about partnership. It's partly about partnership with primary care, because, of course, it's very likely that that our colleagues in primary care are going to be involved with people before they need to come to adult social care. So we'll be working, I think, more closely with primary care to look at something that's often called case finding, which is about identifying those people who might be beginning to find some difficulty managing and become involved with our partners in primary care with those individuals earlier. I think the digital technology will help. I think the more we can make our services available through our websites and other technology platforms, that will encourage people to come forward. And I think probably as we develop our front door, we'll want to publicise it properly and make sure that people are aware that it's there to support them and provide information, advice and services. But you're absolutely right. You know, there are people who every day are beginning to struggle, are beginning to manage less well, and that one of the challenge for us is, how can we reach out to those people and provide support to them?
I just have a question myself. How do we protect these services which are going to be about reaching people at an earlier stage? Because quite often people working get overwhelmed by the need of people with much higher needs. So will somehow these services that are much earlier be ring-fenced so that social workers aren't overwhelmed by the needs of people with much higher needs that have to come first and end up taking up resources?
Well, I think probably I could point that there's additional investment, for example, going to primary care. It's not a social care service, so I probably can't talk about it with any expertise. But we are seeing primary care networks beginning to employ different types of professionals and support workers. So there is a little more capacity in the community to support people perhaps with lower level needs. But as I also mentioned earlier, we've been running bathing clinics. It's a lot more efficient to have a community-based centre with a series of appointments and invite people in to those appointments. We know from the bathing clinics, people really don't mind. Historically, in adult social care, we've visited people at home, and we've tended to make those appointments at times that are convenient for individuals. But actually, if you look, for example, at GPs, all of us as citizens are usually perfectly happy to make an appointment and visit the GP surgery. So I think for us in adult social care, we need to adopt more of that model, not just for bathing clinics, for OTs, but for social workers as well. And whilst we do need to see people at home, particularly with more complex cases, I think probably if we can see people on that appointment basis at particular clinics, actually we can see a lot more people with the same resource. And actually, at the same time, we can reduce some of the carbon emission that's associated with our social workers travelling around by car. So I think probably it's about working more efficiently in order to reach a greater number of people. And as I've said, over year 2 and 3 of this project, we need to develop our digital resources, because of course that's another way of reaching lots of people with limited resource.
Thank you. Councillor Trent?
Yeah, thank you, Chair. I think one of the things that has been developing over recent years with austerity in the background has been the early intervention and the people not being taken on board as having a need until the need is much greater, and hopefully this maybe addresses some of the issues that could sort of replace that. But I'm actually wondering, you talk about primary care being sort of part of the link. whether there's the need for a much stronger link with the GP practices in identifying people that have needs and taking it from there. Because I think the earlier that you can get involved with someone that's got a problem and the earlier you can put help in place, then the more effective it's going to be and the longer it is before they reach urgent care. And whilst I think this is possibly a move in the right direction, I'm kind of wondering whether there's scope for strengthening the links even further, so that whether it's spotted at a GP or wherever it's spotted, oh, this person's got an issue and we need to kind of help them out with it, you know, how that works with it.
I think you're right. I think we've a lot further to go. We know that working closely between adult social care and GP surgeries already works very well. Most GP surgeries have multidisciplinary team meetings that bring together social workers, community nurses, GPs, sometimes other professionals like occupational therapists, physiotherapists. And those are multidisciplinary teams that actually get around an individual who has needs and provides a multidisciplinary response. And we have specialist workers called case support coordinators who aren't qualified, but they help to coordinate that work and make sure that the needs of individuals is followed up on and the professionals are connected together when supporting them. So we've been doing that for a number of years. We know it works, and hopefully the front door working with GP surgeries will allow us to expand on that work and reach even more people. But you're right, it's a journey. I'm sure this will evolve over the next few years as we develop closer integration between health and social care.
Thank you. I understand we have Sally Sancroft from the CCG here, who may wish to tell us a bit more about the work that they do.
Evening, everybody. Yes, Sally Sancroft. I suppose it's probably helpful for me just to share that we've got quite a lot of resonance in terms of a recognition about the benefits of identifying and connecting with communities and understanding people's needs a lot earlier than we currently do. I think over the years what's happened with all the pressures in the system, of which they're very live in primary care as they are in every other part of the system, is there are absolute merits in understanding the populations better and those people that are vulnerable within them, and really connecting with a wider group of people that can help us to do that. So when I say connecting with communities, we've got lots of local community champions, which you'll be very aware of in our communities, that traditionally maybe the statutory services haven't always connected so well with and not pulled on their knowledge so well to understand the people in their communities. So we're really keen, and so are the primary care networks, to really look at how they can do that better. And also David mentioned around using technology. So using, there's some really good digital technology that helps us in an automated way understand from GP registered lists who are those people that are demonstrating indicators that are likely to escalate their needs if we didn't intervene earlier. So not only using the knowledge of communities, the knowledge of health and care professionals, but also using risk stratification and the technology that brings with us. A combination of those things helps us to understand who those people are that might benefit from earlier intervention and support. And that means it improves their outcomes, improves their experience, combined with the strengths-based approach that David referred to, which is really looking at what potential those individuals have got as well as what needs they might have, really, I think, benefits not only them but all of the parts in the system. And we've got some really common resonance in terms of a vision to achieve that.
Thank you, Sally. We still have some more questions, so maybe. Councillor Rocker.
Lucky. Thank you, Chairman. I got a couple of questions. The first is about the implementation plan. I can see that the new adult social care front door becomes operational in 2020-2021. But when actually people will be able to use this new model? So will it be gradual, or there will be a starting point, and then because also the plan is going in 2022, 2023, So, and the second question about the customer contact. There is this self-serve digital portal that is quite interesting. But I'm a little bit worried because there are a lot of people that are not very digital user-friendly. And even in my age, I know a lot of people are not able to do a lot of things online. And then I can imagine people over 65 or 70, how they will be able to start this process. So there will be a front face service, or will be just on the phone, or will be only digital or something like that. Just to give an example, I'm European. Now I'm British as well, but I done the European Settlement Scheme in February. It took 10 minutes for me to do that, just with mobile my passport. At the moment, there are, in total, I think there are 3 million people interested in this process. And there are a lot of charities like Citizen Advice, a lot of different associations helping people to do this process that it takes 10 minutes. So I'm worried a bit about this digital part of the customer contact. Thank you.
To answer the first part of your question, our aspiration is for the service to go live in April of this year. So that will mean taking our 2 current front door services, joining them up into a single service, finding a name for them. We'll appoint a manager and bring the staff groups together. We'll also then begin to look at bringing in occupational therapists and social workers and safeguarding experts from our long-term teams. This won't be new staff, but our understanding is if we can bring these staff from our long-term teams right up to our front door, that will avoid a lot of the demand that would have fallen back to those staff in any case. So those are the things we're looking to do fairly immediately for April, so that as far as our residents are concerned, there'll be, I hope, 1 single phone number for adult social care front door and 1 single response. And we'll be able to do some of that, that more qualified response within the first year. And as I said earlier, the years 2 and 3 are much more about developing the digital offer and building our relationships with the voluntary sector and understanding how we can integrate more closely with primary care. So the service will be up and running. People will experience a difference from April, but then it will be an evolving service over 2 or 3 years. In terms of the digital offer, you're quite right. Fewer than 700 people at the moment actually make contact with us through the website and complete a self-assessment. I don't think technology's really caught up yet with the way people want to use it, but we expect that will happen in the next couple of years as apps become more sophisticated and BCP develops its website offer, and we're able to update My Life, My Care, which many of you will be aware of is an information service across BCP. I would say, though, that it'll run alongside our telephone response and our visiting officer response. At no point will we ask our residents only to contact adult social care through digital methods, because we know it's not going to be right for everybody. But we do know now that some people have family members and friends who would sit down with them next to a computer or a laptop or a tablet and help people access our services online. And I think increasingly all of us are becoming more expert at using technology, and I think as the years go by, more of our population will want to do that, will want to enter assessment details online, ask for help, and actually receive advice and information online without ever talking to us. But it'll never replace our personalised offer. It'll always run alongside it for people who want to use a digital access point.
Councillor Ampton.
Yeah, thank you, Chair. Thank you, David. That was a really good presentation. I do absolutely get that the direction of travel is this strength-based approach, no doubt in most authorities. I couldn't see anywhere in the paper, I can see what you're hoping to save, but I couldn't see what the actual budget is for the new service. Have I missed something, or is it not in the papers?
No, we haven't yet developed a budget. The global picture is that this will be a zero-cost service. We're not removing any resources from it, or rather we're not removing any resources from adult social care, aside from the savings we have projected, but equally we don't feel we need to put any additional resources in either. This is about moving staff from our long-term teams up to our front door in order to make sure it's equipped to deal with a response. As we develop the service, as we understand how many staff will need to move, then we'll have a much better idea of what the overall cost of the front door is, but that hasn't yet been modelled. But it's not looking for additional investment in order to happen.
So I am quite concerned, Chair, because it does seem a very large sum of money to be taking out of the service. 2.5 million over 3 years is substantial. And I'm just kind of thinking back to when we've had conversations about hospital and reducing the demand in the hospitals and putting it into prevention instead. So by not taking on extra resource and taking people who are already in the long-term teams and having them do this job, how does that work? Because surely you're leaving a bit of a sort of a potential gap in those long-term teams for dealing with the current demand, because this isn't something that will happen overnight. This is something that will build up in time. It'll have to be advertised. People will have to get used to working in a very different way. So I'm concerned about that. I'm concerned about the amount of money being taken out. And I know that you've said that you expect to save on, you've got sort of packages of care savings that you can't actually identify at the moment, because obviously how can you? You can't, you can perhaps model it, but you don't know for sure. So isn't this really a case of you're kind of kicking the can down the road?
I don't think we're kicking the can down the road, but I do think we're making a leap of faith, because what we're doing here is cutting edge. KPMG have looked across the country and brought some of the best ideas from elsewhere together. But actually we're looking to do something here that's more advanced, more sophisticated than anywhere else at the moment. And so we have to make some assumptions about how it'll work, because the evidence is limited. But I mentioned earlier that we brought some safeguarding experts into our front door in Bournemouth, into Care Direct, and it halved the number of referrals that were passed back for long-term safeguarding investigation. So we know that by bringing people from long-term teams up to the front door, we absolutely can reduce demand. So we can justify bringing those staff up to the front door. It's the same perhaps, and I'll return to the example of a fall. If we can use an occupational therapist who's currently in a long-term team and currently now providing people with care packages and equipment because they've fallen and broken their hip and lost their confidence, if we can bring that occupational therapist up to the front door and actually do some falls prevention work, then we remove the need for those long-term occupational therapists to do some of that work and for us to provide care packages. So we know there's real benefit in supporting people early. That does reduce the demand for our long-term teams, and it does justify us being able to remove some resource from our long-term teams up to the front door. But we will be experimenting, we will be reviewing this. But our level of confidence in those savings is high because, as I've said, it's actually relatively marginal avoidance of demand to reach £1 million, simply because care packages are so expensive.
Thank you. Chair, just two more questions, if I may. You talked about the third sector, and obviously they're a valuable partner. Is there going to be investment in the third sector to enable them to support this?
I think probably it's too early for me to comment further on that tonight. It's undoubtedly one of the pieces of work that we'll need to do as we develop our adult social care strategy and as we develop this front door. What we are clear about is that we would like to develop more formal links and partnerships with certain voluntary sector organisations that might lead to investment. And we do currently invest in the voluntary sector. The question is whether we can invest more effectively and in a way that's more up-to-date and more consistent with the aspirations of our front door. So I probably can't give you any more information today about that, except to say it's a very clear aspiration that we engage more constructively with the voluntary sector than we have done in the past.
Just last one. Actually, it's probably not for David, because you've already expressed that you're very confident that you will be able to make those savings, and it won't be to any detriment in the the long-term teams, for example. I'd just maybe like to ask the portfolio holder how confident she is that this approach will work.
Yes, thank you, Councillor. Yes, the short answer is yes, very. I would also like to say that the approach working and the cost cutting, I've been longing to come in. I've been gesticulating at David's back there. I think one of the councillors said about austerity and all of that. Although, obviously, we want to save costs, the approach that we're getting here is to prevent people coming into our system for their own benefit, not just because of cost. Clearly, Councillor Rampton is asking about the cost element, and yes, I'm very confident. I think it's going to be a state-of-the-art thing, and I think, as David says, I don't really think it's a leap of faith. I think it's, we're going to be working very carefully through it, but my confidence is pretty high on it. But as I say, even, obviously we hope to make so many savings that it'll be brilliant, but even then, it is very much for the good of the client. In fact, trying to prevent a client becoming a client, and I think that's also something I'd like the committee to take on board. Did that answer, Karen? Thank you.
Councillor Allen.
Thank you for your reply. I'd like to pick up on my colleague's comments. I think that the concern I have is that if you are bringing the staff to the front door, you're almost asking them to do two jobs for a while until you get that knock-on effect of actually potentially being less demand. And I noticed that skill mix is one of the things that you had in your little funnel that you're looking to cost save. So I'm a bit concerned that this is going to be an extra pressure on staff, and you've got to get your skill mix right. And I'd like to be reassured that that's not going to, one, put too much pressure on the staff that are already in post, but also that skill mix work is not going to end up actually having perhaps lower grade, less skilled people doing lots of signposting, but you still need to have those really experienced professionals. And I just wonder how you're going to support those people in those changes in roles, but how you're going to actually manage that if you want them at the front door, but you also want them in the background, and what your skill mix is going to look like going forward. Thank you.
I think that's a very good and helpful question. We're still actually developing this project. We've only recently had the recommendations from KPMG, and we're now actually saying to ourselves, so how do we make this happen? And one of the questions we're asking ourselves is, what will be the process to ask our qualified practitioners who work in long-term teams to work at the front door? I think a lot of the answer is that this will be a gradual process. We're not going to move lots and lots of staff in one go. I would hope that we can move people who are really keen to try working at the front door on that much more rapid, fast turnaround work. So my hope is that we won't be pressing anybody to move, but we'll be looking for people who would enjoy that type of work and moving people very slowly, so we can very carefully monitor the impact on our long-term teams, prevent any detriment, but actually allow us to start picking up some of this new way of working. So I think very gradually, very tentatively, with a lot of monitoring is the answer to try and balance the demand both on the front door and our long-term teams. But you're quite right, it's an area of risk that we'll have to watch very carefully.
Councillor Evans? No? Okay. Thank you very much then, and thank you for answering the questions, and thank you, Councillor Dedman, for coming and answering some questions, and Sally as well. So I think we'll be very interested in how this develops, and would like to have a progress report during the final quarter of 2020 to 21 for scrutiny, please. Thank you. So now item 8 concerns the budget for 20 20 to 21 and midterm financial plan assumed savings, and this is the second of the items that have been added under AOB. For context, this was suggested by the Overview and Scrutiny Board at its meeting on the 13th of January, that the Health and Adult Social Care, this committee, should consider the impact of the proposed savings for adult social care upon service users. So I'm going to ask the relevant officers, please, to go through one by one and give us an explanation and a chance for questions.
I'll just take the opportunity to just repeat what the Chief Executive said actually in the Overview and Scrutiny Board, which is there are just a couple of items here which would require staff restructurings where they haven't been embarked on. There is a limit to what we can say because we have to follow formal process. So just to note, there will be a couple of things where we can give broad outlines, but we wouldn't be in a position to share detail because that wouldn't be in line with the way in which we approach work with our staff.
If I can kick off, Chair, I think the first item is mine, and that's item number 8, which is the base budget review and rebasing of legacy demand assumptions. This is simply the fact that we made certain assumptions about the level of care needs of people in Christchurch who transferred from what was Dorset County Council, and actually found that the level of need for residents in Christchurch was somewhat below our anticipation and the sum we'd budgeted for. And so because of that, we're able to release £1 million into the MTFP. Apologies, Chair, I'm looking at clearly a slightly more out-of-date chart. It's not item number 8, it's item number 1, just for clarity. So I've just described item number 1. Item number 2, I'm happy to answer any questions, but I think probably that's been covered in the previous item.
Good evening. Item 3 is around additional funding through the Better Care Fund allocation for next year. We received just under 5% increase that comes via the CCG. That increase is mainly used to fund inflation within the cost of care and staff. Item 4 is a bit of a double act in some ways. So the use of technology in meeting care and support needs, that is, David's touched on that in his presentation around the front door. This is about how we use assistive technology to complement care and actually keep people more independent and not have as an intrusive package of care where people are coming in and out of your home all of the time, but it complements the personal care. It's not to replace personal care. And the next one is around domiciliary care costs. So when LGR took place and Christchurch joined together with Bournemouth and Poole, we had different framework contracts. Framework contracts are just the means that we commission the care at home. The Dorset framework had been let on a basis of a higher rate, fee rate to providers, many of whom are already working with Bournemouth and Poole Council. So the new BCP framework has encouraged those providers to join that framework, and we commission all new packages against that framework, which is at a reduced cost, which should lead to some efficiencies and some savings over the next 2 years.
I think we're on to item 6 now, which is looking at how we fund high-cost packages. I've mentioned earlier that just an average placement can cost £37,000. Somebody with complex needs actually can cost twice or even 3 times that amount. So in the context of very high-cost packages of care, £150,000 It's not a very large sum and will not be applying to many, many people. But it's an opportunity for us to continue to work in partnership with the CCG, particularly in terms of looking at joint funding for people who may have complex needs, part of which are health-related, part of which are social care, or actually to look at people who need mental health aftercare. And we are already working with the CCG on mental health aftercare, where there may be some individuals we've identified who we can provide care to more effectively. So it's not a very large-scale programme, but it is about recognising that in partnership with the CCG, we may be able to find savings across some of these very high-cost packages.
The next item, number 7, is a review of reablement service. So again, a very similar picture, 3 legacy councils, 3 slightly different ways of approaching reablement. That's short-term care to support people back to independence. So this is a review of the 3 services to come up with a single approach, which will give us a more effective best practice service, we believe, and also look at closely with the interface and with health colleagues around the rehabilitation services that Dorset Healthcare provide, and how we can come up with a single model that reduces duplication.
Item 8, I think, probably connects back to the front door in some ways. We know that every week, and the number varies, but it's not unusual to have 3, 4, 5 people across BCP who have funded themselves in a care home and actually have run out of money. And so they revert to us as a local authority to pick up the cost of their care. Now, if we can support people at the point at which they go into a care home to find the right care home with the right quality of care and, importantly, the right price for their care, it's likely their money will last longer and they're less likely to come to us as a local authority, or at least as early to us as a local authority, to pick up their funding. And so £100,000 in 2021-22 we think is a realistic sum, particularly as, again, given I've mentioned it's quite a lot for a single individual placement. It's just about avoiding the local authority picking up the cost of some placements by helping people to make better choices. There's no saving in 2021 because obviously advice we give now actually won't begin, as it were, to pay off until a year or so down the line, when people's money may otherwise have been running out.
Thank you. So moving on to item 9, review the commissioning of dementia home care in the Pool area, similar to the framework discussion that the item I mentioned earlier. We've got differential approaches, so we just need to review and make sure that we've got a single approach around the way that we commission home care.
Item 10 is around direct payments. When one of our clients receives a direct payment and buys their own care, we give them a reserve, if you like. We give them enough money to buy the care, to buy 8 weeks' worth of care ahead of time. And we do that in case they run into any sort of difficulty. It means they've got enough money in their direct payment pot to keep themselves afloat and to make sure they can carry on buying care. But actually that's quite a lot of money, and most of that money just sits in individual people's direct payment accounts, unused. So we're adjusting our processes, and we'll be giving people 6 weeks' worth of direct payment as a contingency instead. That's more than enough to see people through any difficulty they might have in buying their care. And actually our argument as well is, well, if somebody gets into any difficulty, they only have to contact us. And we can either put more money into their direct payment account or help them make other arrangements. So it's really about taking surplus money out of direct payment accounts where actually it's not achieving anything.
Next one's yours.
Oh, it's mine as well, is it? Apologies. So item 11 is about the shared lives scheme. Shared lives carers are people who care for somebody, usually with a learning disability, in their own home. And for that, they receive a sum of money. That money is made up of 3 components. It's made up of the care costs that we pay as a local authority, the daily living costs that the person they care for pays for, things like food, for example, and it's made up of rent. which comes through housing benefit. And over the course of the last few years, particularly the rental component and the care component have fallen slightly out of step. And the rent is actually lower than it ought to be. It's lower than housing benefit rates. And so our intention here is to look at raising slightly the rent that shared lives carers charge to the person they care for, which will be paid for by housing benefit. And that means we'll be able to reduce slightly the care costs, which in recent years have been used to offset the lower rent. So in actual fact, the clients that are cared for by shared lives carers won't see any financial impact. They'll just claim a little more benefits through housing benefit. The shared lives carers will see exactly the same amount of income, just in a slightly different ratio. And I think there may have been a question about the tenancy status of shared lives carers. So just to say that although as a council we provide licences to landlords, or we license landlords, shared lives is actually outside of that. And instead what we do is we arrange a legal licence between the shared lives carer and the person they care for. And actually that's a licence to occupy that person's premises. So it's very different from a landlord and tenant arrangement. It's a very specific arrangement that's exempt from general landlord licensing from the council. Item 12 mostly relates to our financial services, and really these are just efficiencies. We're looking at how we can use technology to better process our finances, and by that we don't mean the accountancy and budgets that we use for adult social care. We mean our payment of care providers and our billing of our clients. So we're looking at making the process more efficient through IT. We're also looking at where we can be more effective in terms of debt recovery. If debts are allowed to continue for too long, it just takes more officer time and sometimes legal time in order to recover those debts. If we can work with people who are beginning to have difficulty paying earlier, it just avoids some of those administrative costs to us as a council of recovering debt. So really it's just about a bundle of efficiency savings within our finance teams to reduce the cost of administering payment, billing and debts.
Item 13, reviewing the model of night care. Again, we inherited several different approaches to the delivery of night care. That's going into people's homes during the night to help them with toileting or relief of pressure by turning them, adjusting their position. So technology has moved on much more than when we first commissioned these services or provided them internally, and things like mattresses that can adjust electronically, that saves you having to wake someone up to then adjust their position, can be less intrusive and actually much more effective. So we do have occasions where we're actually waking people up, and that can't be good for either their sleep or their independence or intrusion into their lives. That's just one example, but we were looking at creating an approach that offers an equitable single approach across BCP rather than 3 or 4 different approaches that we have at the moment. The next one is around staffing savings through the bringing together the management functions around adult social care commissioning. So I'm partway through that structure now, which has already delivered some savings, and further approach around rationalisation of management, where we've got bringing the teams together to provide that single approach, should release further savings, which are identified here.
I think item 15 is mine. So we provide catering services from adult social care to certain extra care housing schemes and day centres. That's been provided by different catering teams across the preceding councils, particularly in Bournemouth and Poole. This is a proposal to bring that catering provision together, and so we can provide those meals more cost effectively by doing it as a single catering provision service rather than 2 separate legacy catering systems. Item 16 has been seen by this committee before, and so I won't talk at length, but we are at the moment consulting on our charging policy for adult social care. If we do proceed, it will harmonise what our clients pay across Bournemouth, Poole and Christchurch. Really, we're doing it to harmonise and make fair our charging, but there will be, we believe, a modest increase in the amount of income we recover as a result of the new policy. Thank you, Chair.
Thank you for all those explanations. Do we have any questions? Councillor Rampton.
Thank you, Chair. Probably the same question applies to several of these items, but I'm just going to ask you about items 13 and 15. Are you talking any reduction in the service provided, or is it simply getting a better overall price?
It's a combination of things. So we will be looking at how do we get the most effective model, and I gave you that example of how that might bring some efficiencies. If normally these things happen where there's two people go out. So if we've brought technology in to support people, then that's an immediate saving that we don't need to use that resource for that. But there's also something about how we make an approach that we review our practice. The review hasn't taken place yet. It's in train at the moment. But when we've looked at it, that it seems reasonable to take out that level of efficiency just by those simple examples of technology taking place of personal care. Does that answer the question?
Not entirely. So there could be a reduction in service, for example, with the catering service. Or is it just getting a better price?
Sorry, I was
overall?
picking up. I'll let David answer.
In terms of the catering service, there's no intention of reducing either the quality or the level of provision. This is simply a matter of how we organise and run our kitchens, and we think we can do that more effectively as a single team rather than two separate teams. So there's absolutely no service reduction associated with the catering changes.
Chairman, can I just come in, because the night care one was one that we had the question on, I believe, at the other overview and scrutiny board, which is not this one. And I did stress there, but I think Councillor Green asked a question about reduction in night care, and our review is starting from no diminishing of the services. So that's where we're starting from. And as for the catering, yes, I think the service will be the same, the custard will be the same, it will just be coming from a different kitchen, which will make it a saving. So nobody should notice anything.
Councillor Evans?
No real questions. I just wanted to say congratulations. This must have been a huge amount of work, and you've managed to save a projected 5.5, just under $1 million over 3 years, with minimal impact on staff or service provision, and I think that's absolutely to be applauded, so thank you very much.
Do we have any other questions?
Thank you, Chair. Can I just ask something about the reablement service? Now, I presume if A&E and the hospitals are experiencing high demand and on their beds and the bed blocking that goes on, how is our reablement service coping with that in conjunction with the hospital? Are they managing to take these people out of where they're blocking beds? Have we got sufficient reablement places for this?
I think it's a combination of things, Councillor. So yes, they do receive. So reablement is a service that you've got to meet a certain level of criteria to access it, because there's got to be some ability for you to improve your skills and ability to function. So yes, they are picking those people up, and they do help out at times of pressure within A&E with just support to individuals. So there's a combination of things they do, but that's in conjunction with the wider commissioning of care that we do with the independent sector. So it's not just one service that meets all demands. So it's spread across a number of services. Does that answer where you're coming from?
Well, it was just sort of having seen where someone I knew, she'd broken her hip. She was in hospital for so many weeks, but obviously she still wasn't quite right to go home, so she used your reablement service before she could then take up the care package. You know, it's that sort of steps that they go through before they actually go back to being independent sort of living. And I just wondered how much the pressure was on that service that you have.
Yeah, I mean, there's pressures on all services. I think has been picked up. The hospitals have been facing significant pressure over the last few months, and that's through a combination of things. People who have had a crisis like that, where they've broken a hip or a wrist or things, might get a combination of services which include rehabilitation through physiotherapists and OTs that health provide, and then rehab might come in if they've lost some skills through that episode. So they may have less use of one particular, they may be right-handed and need to use the left more, and so they'd be retrained in daily living skills by the rehabilitation service. So it all depends on what part of the journey you're on. But I think in times of crisis, our services have come together as best they can to support our NHS colleagues.
Is that all the questions? Okay, thank you very much. Okay. Item number 9 is the review of local safeguarding adults boards, and Barry Crook is the independent chair for the BCP Safeguarding Adults Board and is here to present his report following the study that is attached to our minutes agenda even.
Thank you, Chair. Good evening, everyone. This is the first opportunity to report to you as to where the point we've reached in reviewing the Safeguarding Adult Boards, not just the BCP one, but of course the Dorset one as well, because for some years the two boards have worked together in the particular kind of model that we have in this county. I think I want to say also that in terms of timing, the timing of this review for the Adults Board is probably much more within our own gift than it was for the Children's Board, because that had to be delivered by a certain deadline. So the timing of the two boards has been a little bit out of sync, but this one, the timing feels a better time in a way, because local government review has been completed. You are two new authorities, and it is an opportunity to take stock as a lot of things change in the governance framework and say, is this the right model for us going forward? So the partners on both boards agreed that as a first step we ought to commission an external review of where we were and identify some of the strengths and weaknesses, and compare hopefully with some emerging models in other parts of the country where different safeguarding adult boards are taking a different direction in terms of their structure. So we commissioned John Goldup, whose report you have in your papers, and set out quite a range of issues for him to look at that would enable us to move forward on this question. He was obviously got a very strong track record in Ofsted, and himself chairs safeguarding boards in London. The review was delivered on time for us, and we felt, having looked at it as a commissioning group, that it provided a useful starting point, but didn't really take us as far forward as we might have hoped from the original specification we'd set out. And you'll see that he sets out a range of kind of positive references about the way the two boards work together, particularly the way in which some of the subgroups develop their work. But he also identified some areas for improvement that we can work on, and which we would want to try and build into any new structure that may be agreed between the boards. And the two, I think, that jumped out for me were in particular about having a better line of sight in respect of what safeguarding practice is on the ground and how that performance is measured, and also something that wasn't new to me because people often raise it, the fact that the Pan Dorset organisations that sit on both boards do deal with a lot of business that is the same for both boards. So those were kind of two particular issues that we felt we ought to address. Where we didn't feel the review took us as far as we wanted to was about alternative models of governance, and perhaps looking at some other options that are being delivered not too far away from here, where in Bristol, for example, and in Bath and North East Somerset, they have brought together the functions of community safety, children's safeguarding and adult safeguarding into one structure. And they each have a slightly different way in which that structure works, but it is an evolving model that probably for both authorities is based on the fact that although there is what you might call a traditional adult safeguarding role in respect of elderly care, a lot of the emerging issues around adult safeguarding have been those that we've shared with other partnerships. So domestic abuse, exploitation, county lines are all ones where there's a shared perspective, and it is felt actually we need to work much more closely with our partners than we have done before. So if I take you onto the second page and 2.3 of my covering report, the commissioning group proposed the following recommendations to a joint meeting of the Safeguarding Adult Boards in December. And these were broadly agreed that we should try out having, in order to produce some efficiencies in travel and business time for the Pan Dorset agencies, we ought to try and have both boards on the same day and have a kind of tripartite structure with the first and third parts being a local single board part of the agenda, and then a middle section where we'd look at issues of common interest, which would include some of the work around the subgroups that they are undertaking, but also might be some quite interesting and development work we'd want to look at together. And one of the things that we're proposing for the first meeting in March is we look together at our large-scale inquiries that have been undertaken in both authorities where there's been concern about safeguarding in particular providers. So that's about to kind of happen in March. The second bullet point is very much about trying to improve our quality assurance arrangements and ensure that we do have a better line of sight on performance, and I think there are several things that we can do relatively quickly to try and focus upon that. But then the third part was deciding that we do still need to look more closely at the governance arrangements and the structural review across safeguarding and community safety, and look at what options would be best as the two authorities evolve in their own particular way and taking account of the emerging threats to safeguarding. So it was agreed that a leadership group would be set up at a fairly high level strategically, which Jan is coordinating, to develop this particular piece of work. And that's been endorsed by the chief executives of the relevant organisations. And then in the subsequent headings, I've just picked out one or two points of relevance to the review of the boards. One thing that the John Goldup review didn't really tackle was financial contributions to the boards. And many of these are based upon quite historical arrangements that probably don't fit very well nowadays in terms of the way in which practice has evolved. And also we've not looked at whether some of the improvements that we would need to make would have an additional resource cost, or whether further efficiencies can be made in any new structure for the boards. So that piece of work does need to be addressed in the next stage. In terms of the legal implications, it's quite important to note that for adult safeguarding, the statutory responsibility stays with the local authority, although the police and the CCG are core partners, whereas in respect of the children's arrangements, there is a different and more equal responsibility across the three organisations. So that may have some influence on the kind of arrangements we end up with. If I move on to the public health implications, we've done a lot of work recently with other partnerships, particularly Community Safety Partnership and the Children's Partnership, less successfully with the Health and Wellbeing Board, and that is probably an area for us to focus for the further structural review as to how we align better with the agenda of the Health and Wellbeing Board, particularly as adult safeguarding does also have a prevention responsibility set out in the Care Act for us. And I think there is a case for looking at whether public health ought to be represented on the adult board or boards, whichever approach is adopted. And then finally, there are some tensions in this review, inevitably, and they're not new ones, but ones that will have to be where we'll need to try and find a better fit. I think it is a challenge for the review to decide what arrangements will be more flexible and enable us to kind of be lighter on our feet in anticipating new safeguarding issues that evolve. And I think county lines is a particularly good case where we're still grappling with the question of, well, what's adult safeguarding contribution towards preventing harm to adults through county lines, which is primarily a CSP and police responsibility. So I think that involves finding a better way to use intelligence and to support prevention across the system, and ensuring that we have a good fit with the other partnerships that we do engage with. I think there is a risk also that if we centralise around the core partners to the Adult Safeguarding Board, that we lose the commitment of the wider partnership that's so essential to delivering safeguarding well. And I think that's a challenge for the review to ensure it doesn't happen. And of course, there are continuing budget pressures in all organisations on the boards. And how we maximise the new arrangements from following local government reorganisation to be more local in the approach to adult safeguarding, whilst being responsive to the concerns of the Pan Dorset agencies for a whole county approach, and the impact that may have upon their resources is probably one of the more difficult issues that the review will need to resolve. So I think that summarises where we are, except that I would say that we're not starting from a point where we have to have a wholesale review because safeguarding is not working. I think we have a lot of good positive practice, and it's about how do we get it into a good shape for the future to ensure that it takes account of local government reorganisation, but also the new kind of threats that there are within adult safeguarding now.
Thank you for coming and presenting your response. Can I open it up for any questions? Did you have a question? No.
Yeah, I'd like to take one aspect of it. It's probably the bit that least links to health, but you mentioned that the different authorities work together on county lines and the problems caused by that. And I'm assuming that the adult safeguarding is those that are victims of cuckooing and things like that. And I think they do. The people who organise that do sort of, pick on the most vulnerable people, adults and children. But actually, sort of, the Bristol and Bath model, bringing together community safety with that, does that work better? Because community safety is quite a wide thing, and it isn't just safeguarding. Does that actually work for addressing the community safety side as well as the safeguarding side?
I think for those two authorities it's too early to say yet, because they've only just brought that model into operation. The Bath and North East Somerset one started in September, I think, and Bristol were advertising for an independent chair as late as the autumn. So I think it's too early to say if it works. But I'm hoping I'll be able to get a kind of insight into how it's beginning to work from my colleagues in the region.
Can I ask, Chair, that we have a cross-cutting report on how that works at a later stage. You know, it needs to be this scrutiny and other scrutinies, because it sort of affects a lot of areas that, from the point of view of the communities that we represent, you know, a lot of these areas, it's present in part of the ward I represent, but it hasn't sort of spread throughout. But it is a very important issue, and I think, because what I wouldn't want is for the work done on that to be watered down by just looking at the safeguarding side. But it's an interesting concept, and I would like to understand how it does actually sort of pan out where it's being operated.
I've just, with the Chairman's permission, I'll comment. So, as you can see in the report, there's been an agreement that the statutory director is responsible for adults and children and community safety across the two councils, and the Assistant Chief Constable and the Director of Nursing in the Clinical Commissioning Group would form a group to look with others, such as Barry and his independent role, at what would be the best model. I think we know that any model will have its pros and cons. I think in terms of timescale, I would be thinking at the moment that this piece of work will take a little while to do. I think you're quite right, Councillor Trent, that when we look at the outcome of that review, we will need to think in scrutiny terms how we bring it back. I think it might a bit determine on where that's taken, but I think you're right that this committee, but also the board and also the Children's Committee would have absolute interest in the recommendations about governance going forward. So take on board responsibility that once we've done the work, we will need to work with the chairman of all of the two committees and the board to think about what's the appropriate way to bring back any recommendations that make fundamental change.
Thank you. Is there any more questions? Yes.
Thank you, Chair. It's just a general one, really, from a case that came up that I knew about. Whereas problems within safeguarding, when you know that there is a vulnerable adult and you know there are problems, but that adult themselves will not recognise that problem, and we have data protection issues there. Is there any solutions that sort of can sort of help get over that sort of well, you're trying to safeguard somebody, but they don't think there's anything wrong with what they're doing or anything, you know, but you can see that there's self-neglect and hoarding and all sorts of things going on, and you feel your hands are tied, really.
Oh, I think you kind of brought out a kind of nugget of difficult practice, really, and that comes up in one or two different settings. I mean, I think it is about, that is often where the social work skill or the skill of partners to find a way of encouraging that person to see their risk comes in. I don't think there's any straightforward answer to it unless the risk is so high that there is a case for overriding their capacity and their decision for nothing to happen. Another good example is you can see it in domestic abuse. We are beginning to understand the nature of coercive control and how that may affect particularly people who have capacity but are not protecting themselves very well. So it's not a straightforward issue to resolve, and certainly won't be resolved by this review. But it's very much about the judgment that we look for in our staff, isn't it? And their skill and experience to deal with those kind of settings.
Chairman, I was just going to say that actually the board benefited from a very good presentation around social work practice in relation to people who do have issues in terms, for instance, of hoarding and self-neglect. And if members mindful to have a training or development session, we can always arrange for some of our practitioners, both within the council but beyond, to talk about some of their practice and how they have worked in those situations. One of the things I think we would say is it is often around the quality of relationship that a professional is able to develop, and often that's over time with someone in that situation. But if the committee at any point wanted more opportunities to talk directly with practitioners about the nature of their work, then we'd be more than happy to arrange that.
Thank you. Is there any other questions? Okay, well, thank you very much. We'll look forward to seeing, hopefully, a report looking at the outcome of your decisions. Thank you. Item 10 concerns the emergency duty service, and this item consists of a report which summarises the activity of the new emergency duty services since operations began in November 2019. And I invite lead officers to speak to the report as necessary before the committee, as per... I don't know what I'm reading there, to be honest. Thank you, Betty.
Okay, thank you. Hi everyone, I'm Betty Butlin. I'm head of long-term conditions, and the emergency duty service has set in my kind of remit. So I'm here to provide you, I've provided you with a report, and I'm here to provide you with an update and just talk you through the report and then take any questions that any of you can have. So if I just take you through the executive summary and then go into a bit more micro detail. So the out-of-hours service until recently, well, not so recently now, November 2018, prior to that it was a joint Pan-Dorset service, which included the 3 authorities at that time. The service that was provided then was for adults and children, and that was up until November 2018, when after a number of audits and Ofsted, it was recommended, after a detailed kind of review into the Pan-Dorset service, that resulted in recommendations that there should be a new service, a new adult service, now referred to as the emergency duty service, known by practitioners as the EDS service, which would be for Poole and Bournemouth adults, and then in April would also include Christchurch. So that's what I'm here to talk to you about, is the adult emergency duty service. There is a children's one which is separate for BCP Council, and Dorset Council are managing and running both their own children and adult service. So if I just take you through onto page 2, a bit of the background, which I've kind of talked to you about. Until recently, the team was located in Commercial Road in the Children's Services building. They moved on the 4th of November 2019 into the Civic Centre, which is a much better location for them. They have other services there, and given that it's a service throughout the night, their safety is paramount because they're in and out of their cars. And I've done it myself. And if you're anyway mindful of the dark or dark alleyways, it's good to have other people around you. So that's where they're relocated, and the staff are really happy being there. The team consists of a manager and a deputy manager. It has 5 contact officers. The contact officers are really skilled call handlers, if you like. They're really able to take people who are in a real time of crisis. This is a crisis service. This service is not for services that are non-emergency at that time. So they're able to talk people through how they're feeling, what they need. People that are in real distress, so they're able to manage that. And there are 5 of them. And then we have 7 mental health practitioners, Mental Health Act practitioners, and the 2 managers. And collectively as a team, they're able to work with partners. So they're able to work with the police, they're able to work with colleagues in health, in acute trusts, in the community, the public, really concerned relatives, really concerned carers, concerned frail and elderly, older people that are really distressed because something's happened to them in their property during the night time. So the kind of hours that the service work. It kicks in Monday to Friday whenever daytime services stop. So round about 5 o'clock. 4 o'clock, there are people coming into the office and stuff, but effectively it's 1700, 5 o'clock until 9 a.m. in the morning. And they work all through the Saturday and Sunday. They're a 24-hour service, and they do that with bank holidays as well. So you have to be quite, the roadies have to be quite flexible, quite skilled. And you can see on point 3 that I kind of talk a bit about what the service provides. It's a single point of access. It is a crisis service. It allows adult care in the council, BCP Council, to fulfil its statutory duties throughout the night. It is really when adults are experiencing some form of neglect or harm, or there's a significant risk. It might be an easy situation for the team during the night, might be where somebody requires an emergency placement. I myself did a shift not that long ago, had an older lady on the phone who had just moved. Her property wasn't suitable for her to stay there that night. There were things that should have been in place that the family just weren't able to get there in time. So her and I talked about where she might be able to go for that night to make sure that she was safe. That's a very easy scenario to deal with throughout the night. Other examples may be where people are suffering with their mental health, and they're just not in a good place at that time, and they need some specific assessments around that. It might be that we need to look at assess them under the Mental Health Act. It might be that we need to meet what we refer to as a Section 12 doctor, which is one of our colleagues that can go out with us as social workers, approved mental health social workers, to sit and listen to somebody and try and help them through a situation where they're really in despair. And sometimes, unfortunately, that may result in them needing to go into a hospital environment for some time to kind of work with them and to treat them to hopefully get them back into a really good place. There's also some situations where we work with our police colleagues as well. And if I take you just through the report, that can be around taking people to a place of safety, people that are distressed, the public, members of the public that are maybe distressed in public places, and the police will attend to them. And the police, through their initial assessment, determine that they're worried about that individual, and it might be that they take them to a place of safety, and then they may contact us to go and to do a joint piece of work with them. And it might be that the police are there, we have our doctors there, and we have our practitioners, our expert practitioners there. And some of those places of safety may be St Anne's. We refer to it as the 136 suite, and that is simply because the 136 part of the Act allows powers to take somebody to a place of safety, and I've talked about that a bit in the report. So that's just giving you a bit of an insight into some of the types of kind of casework that we'll deal with, and the type of skill that we need to have within the team. It's a really skilled kind of group of individuals who love what they do and are really committed to that type of work. The benefits of the redesigned model, you can see I've outlined them for you at point 8, carrying right through. And they are really tangible improvements. They are things that we are seeing that is much better. We're able to give people the time, since collectively Pan-Dorset-wise, we agreed to kind of change the service in the way that we have, that we each have our kind of adults and children's, and BCP do theirs and Dorset do theirs. I kind of had, in the report, I've given you just some very quick statistics just to give you a bit of an indication. On point 10, I talk about a period of time, June to October 2019. And the number of calls that we had just short of 1,600, I think it was 1,600 calls, and talk about how many of them, 231, I think it was, which were kind of more detailed pieces of work, but the majority of them were able to be dealt with by the contact officers, who I said were very skilled, and then other ones resulted in doing visits, doing mental health act assessments throughout the night. The shift that I did, because I like to go and make sure that I'm aware and I'm up to date on things, I worked during the night with the team, kind of from daytime, then went over into the office, and we did 2 mental health act assessments that night, one from an acute hospital environment and then one from the 136 where the police had taken somebody to St Anne's to a place of safety, and they were the 2. And then I talked about the older lady that hadn't got her fridge and her sofa hadn't turned up, so we needed to put her somewhere else. But that's a typical kind of night, and then all of the calls that the contact officers will deal with. So on point 10, I've kind of given you a breakdown of that period of time, June till October, and just a proportion of what the calls were. You'll note there that there are some reference to appropriate adult, and that is where we may need to go to the police station because there's a vulnerable person that the police are about to interview, and they need somebody, and they haven't got a next of kin or a nearest relative or whatever. I would just stress that they have kind of depleted throughout the early hours in the morning, because it's not appropriate in some circumstances to be interviewing really vulnerable people in the early hours when they're tired and they're hungry and they're lacking in sleep and whatever. So they have kind of gone down during the night, which we're pleased to see. And then 5% of them were safeguarding. And one of them could have been the situation that I referred to. Also with safeguarding, it's about making sure that you pass them over to daytime services. Daytime and nighttime services are really joined together. They can't function if they're not. So they work in real partnership. 54 out of that 1,600 nearly offence were kind of around mental health act assessments, and then there was one, how much was it, 36% I think thereabouts, around the 136, the place of safety. I want to talk just a little bit about an audit that we did. We did an audit in August last year to just get a sense check, because we've invested quite a lot of money in this new service. We've got more staff, we've skilled them all up. It needs to deliver a good quality service. So there was somebody separate completely from the service who had no conflict of interest, undertook a scrutiny audit, 50 cases that we looked at, and we were really pleased with the results of the audit. It showed that there was good quality. The assessments were of a good standard. They were in line with the quality frameworks that we have to adhere to under whenever we're carrying out mental health act assessments and under the Care Act. So from a quality perspective, it was really good. One of the things the auditor did recommend was that the managers, when they come on in the morning, that they do an audit of the previous night's work and the previous night's casework that was undertaken, and have a look at the Mental Health Act reports that the staff had written up. And that happens. That's just common practice now. I would say that the managers are also contactable throughout the night and will be around up until a certain time into the evening as well. So you can kind of read for yourself the kind of things that we did there. But that is routine now, the audit in the next day. I tell you a little bit about compliments and complaints, and you'll note from that we haven't had any complaints as such, and what we have had is really good tangible feedback in the way of compliments. We've had feedback initially from our partners, the police, other colleagues, hospitals, saying that they could really see an improvement in the accessibility of the service and being able to spend more time with them, talking through things that may be historic when we were a Pan-Dorset wider service and doing a much bigger geographical area. We might not have had that time and attention to do. And then if you look at 20, going through, it talks you through the financial and the investment. There has been a big investment into the service on point 21, and we're seeing the benefits of that in the delivery for the outcomes of the people that we support throughout the night. and the legal implications. I've just, referred to the Care Act, the Mental Health Act and the Mental Capacity Act. And point 25 is just around the environmental impact, and the staff are really pleased to be in a building that has other people, because, speaking from personal experience of doing some of the shifts, I didn't like where we were before. It was quite dark, and you were walking 2 and 3 in the morning, and there wasn't anybody around, and so it is much better being in with other colleagues and right at the Civic Centre, and you're not parked too far away from where you are. With regard to the public, the impact and the quality impact, it's an improved service because we have more time and it's more discreet and it's more focused for BCP, the residents of BCP. That's me, unless.
Thank you. It sounds like an amazing service. Do we have any questions? Councillor Edwards?
Please go ahead.
Thank you, Chair. It was just about the budget, because obviously your budget went up considerably. I understand the reason why that was. So do you think the budget for 2021 is going to be of a similar amount, or do you think there will be savings sort of made there? Is this money mainly because of the remodelling?
Yeah, I think to kind of understand the increase, when it was a Pan-Dorset service, whenever everything kind of separated, we hadn't got the same infrastructure as well, so there was some of that needed to happen. With regard to the current staffing, because the staffing is the bulk, where we've had to use locums and we've had to use others who aren't part of the team because of maybe historic people being off sick and those kind of things. At the minute, we're out to advert for one approved mental health practitioner. They are naturally very difficult posts to recruit to. So we're delighted that we've got 5 permanent, which, if I'm being totally honest, we've poached from other areas. We kind of tried not to poach them from Dorset because you're just robbing Peter to pay Paul. So we have 2 excellent amps that have come from London that have relocated. So we're out for our final one that we want to recruit to, and we're going to just see how we go. We have a budget for 7, but we're going to sit with 6 for a while and see if there's no detriment to the service, and if there isn't, then that will be an efficiency. But certainly no more investment. If anything, it should bring some reduction, but certainly no further.
Thank you. I work as a GP in the out-of-hours service, and actually I have been very impressed with the new EDS. But would you mind just clarifying for me, is it separate from Connections, and if so, how do the 2 services work together?
Okay, it is separate, but it's about working in partnership throughout the night and throughout the Saturday and the Sunday. I'm really pleased that you've said that you've seen a difference, because a lot of the feedback that we've had have come from the out-of-hours GPs and the police. So I would say that from when the service started in November 2018 until now, we have definitely seen those links with connection with every other partner, with the acute trust during the night, all really, really strengthen. But it is about partnership. It is a discrete service in itself, but it works in partnership with all of these other areas and services.
Would you mind just clarifying over the dates? I got very confused when I read the beginning of the report. It said until November 2018 it was a jointly provided service, but the new service didn't start until November 2019, but Christchurch somehow joined it in the April, and I just couldn't work out what was going on there. Okay,
so the new service formed on the 5th of November. Remember the 5th of November, that's how I remember. 2018, that's when the newly formed service, and then Christchurch joined the following April, whenever, because we had started November 4 months before we became BCP Council. There is a typo, and I've already spoke to somebody in Democratic Services today to say that that just needs to be amended. So you picked up on it. It's the third last line at the executive summary. There's a typo in the date. It should say 19, not 18. So, yeah.
I just wondered if we, not all together obviously, but if we could go and visit the new premises, if that could be set up for us.
Yeah, the team would love you to come. They'd love it if people came and seen the work that they do and acknowledge the work that they do. Any time. Councillor Rumpton, just drop a note. Yeah, all welcome. It's good to come.
Would we do that? Just get in touch with you?
Yeah, maybe go through David, because David can coordinate everything and then direct it to us. But yeah, please do, because the staff would love that, and they love to showcase the good work and the good outcomes that people are getting from the service.
Okay, thank you. Is there any other questions? No. Well, thank you very much. Okay, so now we're on to item number 11, the forward plan. If we move through the forward plan together, and if anybody has any comments or additions or changes they'd like to suggest. So our next meeting, we're looking at adult social care, the Health Watch item, then the NHS looking forward. Do you want to say?
I'll just maybe comment on the first item. While it says adult social care, actually the item on learning disability is a joint report from health and adult social care. So we just need to be clear that that is a joint report on learning disability services and outcomes, including health checks. And the other thing just to note is that you, I think, are inviting Paul People First Forum, People First Forum to come and talk around their own experiences and what they want to say to you about their experiences of services and outcomes. So, but I just wanted to highlight that that actually will be a joint health and adult social care report.
Thank you. We have an extra suggested meeting date, which, if everybody's in agreement with, we'll look at the adult social care strategy only, I think. Am I right?
And the suicide prevention.
And also the suicide prevention plan. So that would be the 27th of April. Are people happy with that? Great. Just on the suicide prevention plan, there's a training session on Wednesday, I think, in the daytime. I went to it the other day.
No, it's Thursday.
It's Thursday.
The
23rd.
The 23rd, 1 to 3. 1 o'clock. Changed.
Just sorry to jump in there, Chairman. Just to clarify, I think the original timing was 2 till 4. I think it's been revised to 1 till 3. If you didn't get a chance to come to the meeting, the session last week, I'd really encourage you to come on Thursday. I think it's being held here in Bournemouth. My understanding of all members have had invites, so if you are able to attend, please let Democratic Services know and we'll add you to the list.
Great.
All right.
Thank you. Okay. So then we're looking at other items that don't have dates necessarily, I think, beyond that.
The 10's done now, isn't it?
Oh, yeah. So we've got the mental health rehabilitation service. Number 10, we we've done now. And then number 11, as we know, because we've been involved, the adult social care charging strategy results will come back to us. And item 12, the dementia services review. And then we have our other work, which we've talked about earlier, the joint scrutiny of the ambulance services and the performance of the NHS Dorset urgent integrated care services. Is there anything more to say?
Chairman, if you're happy for me to just comment in view of your previous discussions this evening, in view of the item around the CSR and the IRP, it now gives us an opportunity to look at setting up a workshop, a development session for looking at your forward plan going forward into the new municipal year. So once we start doing that and we've got some dates, then we can be out to consult you, and then obviously that gives you an opportunity of looking at what you want to scrutinise going forward, and then you'll have an opportunity to allocate those items to specific meetings.
Thank you. I'll just touch on the quality assurance. I emailed everybody about filling in those gaps. I think we have actually just about filled them all now. So we'll get those sent out again, I think. Unless there's anybody else who hadn't come forward who would like to be involved, please get in touch. Okay. Future meetings. If you can note the future meetings and remember that the 27th of April is an additional meeting. And I also wanted to ask members if they might agree that we will hold future meetings for the time being, at least at Bournemouth here. Yeah. Yes? Oh. Great. Thank you. Okay.
Just to clarify, we have put round the table the complete list of dates, which takes you up to March 2021. That's consistent with what was agreed by Council in December, on the 17th of December. So obviously, as you've just agreed, we can then make arrangements for them to be located here in Bournemouth.
Lovely.
And that issue has then been dealt with.
Great, thank you. Yes.
Thank you, Chair. I just wondered if it was possible we could have an agenda item where we have an update from our Cabinet member, and with things like ongoing issues that are being discussed, things like the budget, obviously there's going to be a precept, any forthcoming legislation, the social care funding, health in reference to our homeless and rough sleepers. There's all sorts of sort of issues that I think it would be useful if that's possible, Councillor Dedman, that we just had sort of the work that you've been sort of doing and we can look forward to that may come on our forward plan.
Are you happy to do that, Councillor Dedman?
Yes, always happy, Chairman, to go on talking. Thank you.
Okay, so I think I'll speak to our officers and see how we add that into the agenda as a standing item or whatever.
Yeah, I'm not asking for an hour, you know.
No, I don't think anyone is. Okay. Is there any other business?
I'd just like to add to my colleague's request. I would particularly like there to be an item around the approach to healthcare for homeless patients within the BCP, what the model looks like, what the future is going forward. I know that we have the Homelessness Reduction Board that's recently been launched, and one of the working groups is around health, which I'm sitting on. But I just think for this particular group, it's becoming more and more of an urgent issue, and I would like us to scrutinise what the approach is going to be around the healthcare provision for particularly rough sleepers, but anyone that's experiencing homelessness. Thank you.
Thank you. We'll look to add that as well into our forward planning.
Yeah, Chairman, those are the sort of issues that you may wish to pick up and discuss, and then you can plan for the next 12-month period.
Okay, well, I think that's the meeting over. Thank you very much.
8:15.